I'd like to welcome everyone. I'd like to welcome everyone to our panel on artificial intelligence in healthcare. I want to thank everyone who's here in the room today, everyone who's on Zoom. I know this is a particularly busy time of year, and I particularly want to thank our speakers. I'm going to start by telling you a little bit about the people you'll be hearing from today. You'll be hearing from Dr. Michael Schlosser, who is the Senior Vice President for Care Transformation and Innovation at HCA Healthcare. Just to tell you for a moment a little about HCA Healthcare, they're the largest investor-owned healthcare system in the US. They have 183 hospitals in 20 states that they oversee, 3,000 sites of care, including acute care, ambulatory surgery, freestanding emergency rooms, urgent care, physician practices, home health care, and hospice. That accounts for 42 million patient encounters a year. Dr. Schlosser leads the clinical and operational innovation and transformation for HCA with the purpose of redesigning care delivery via digitally enabled, patient-centered, real-time data and technology-enabled clinical operations. The innovations that he is overseeing are going to affect all of us as patients now and in the future. Our next speaker will be Dr. Claudia Lucchinetti, who is Dean of our very own Dell Medical School and Senior Vice President for Medical Affairs. I have to say that she has been a collaborator with the Center on Aging and Population Sciences and the Texas Aging and Longevity Consortium since she arrived, and we're very grateful to her for helping us bridge connections to the medical school. In her roles, she oversees Dell's Medical's work in education, research, and clinical care, and she directs the university's comprehensive healthcare strategy. In her own research and her transformation of research, she has been a pioneer in applying AI to efficient and effective healthcare. She's had a large impact on the field with regard to AI and healthcare, and her leadership roles at the Mayo Clinic prior to coming to UT, and is advancing these initiatives in the future. Our third speaker will be Dr. Neil Charness, who is a professor of psychology at Florida State University. He is one of the foremost scholars in the field of technology use, aging, and cognition. He has designed interventions to promote healthy aging and cognition with attention to the use of technology and decision-making. As an aside, Neil directs one of the major centers on aging from Florida State University. And at the start of the COVID pandemic, within the first week, his center had instructions on how to use Zoom aimed at older adults, including those with mild cognitive impairment. So he was really foremost. Our center had the connection to that link, so he did a lot. He's been working with machine learning and AI to look at how older adults make healthcare decisions and use healthcare information, and he'll be talking to us a little about that. I do want to say a thank you to the Texas Aging and Longevity Consortium, the Center on Aging and Population Sciences, and St. David's Healthcare for their generous support of this event. I also want to thank and introduce my co-chair on this webinar and in-person panel, Dr. Bo Shi. Bo is a leader in this field and has been organizing and leading this field for several years. The purpose of science, of course, is to make predictions, even when those predictions are what we would call an inconvenient truth. Bo was writing and publishing on the need for digital access for older adults by early March of 2020. COVID hit Austin March 13th. Bo had already published on March 11th about the need for this. So she is really at the cutting edge of understanding and making predictions that sometimes are not where we want to be, but often lead us to where we want to go. So on that note, I'm going to turn this over to Dr. Michael Schlosser, and I'm going to turn it over to Bo Shi, who will be directing the rest of the panel. Thank you so much for attending.
All right, well, thank you for the introduction, and appreciate the opportunity to be with you all here today. Excited to spend a little time sharing with you about HCA Healthcare and our work in innovation and transformation. Maybe just to add a little context for those who are not all entirely familiar with HCA Healthcare, So we are a partner with St. David's Healthcare, which you would all know locally, those there in Austin. The best way to really think about that is that we're a very large healthcare organization that sort of sits behind St. David's, and through the partnership is able to provide support and technology and resources and back office functions, and sort of help that local health system be more successful and more efficient and more effective. So the local teams really sort of drive the strategy and the care delivery and directly care for the patients. And we're an organization that can sort of sit behind them and really help make all those things work better. So excited to be able to share a little bit about how that large organization is investing in transformation and innovation and artificial intelligence, and how that hopefully will very shortly be something that you all can see there in your local health system. So let me see if I can get these slides to advance. There we go. So I'll just quickly, I'm going to give you a little bit of sort of the origin story, if you will, of care transformation and innovation. So HCA Healthcare has always been a company interested in technology innovation, and we've done this sort of in a distributed way throughout all of our 183 hospitals, our 15 different divisions. But we've never really had a concerted, at the enterprise level approach to how we drive innovation and technology, in particular directed at care delivery. And this became a pain point for us during the pandemic because we recognized that our technology platform, and this really was not an HCA specific problem, this is a healthcare problem, our technology platforms were not really designed in a way that they could help solve some of the biggest challenges of the pandemic. So we didn't have the systems in place that allowed us to become a force multiplier for clinicians and nurses and physicians when labor shortages became a massive problem, when surges in volume became a massive problem. And so we did, I think, amazing, innovative things throughout the pandemic, but it became clear to us that our sort of legacy approach to technology was becoming a serious pain point. And so we stood up this entirely new structure, a new strategy that we call care transformation and innovation, with the intent that is on the slide here in front of you to deliver a step change in patient and care team outcomes through 2026 through clinically led integration of technology into care. So a team that would have the privilege of waking up every day, getting to think about, what does healthcare delivery need to look like 5 or 10 years from now? If we could truly leverage the technology now available to us, and in many cases, technology that other industries are already taking advantage of, are well down the path with, what could healthcare delivery look like? How could it become highly efficient and effective and a great experience for everyone involved? Eliminate the administrative burden, sort of a reset button almost, if you will, on how this all works across all of our healthcare systems, and then hopefully help inform how this occurs across all of healthcare. So that stands as a very distinct and different future that we're envisioning than sort of the realities of today. And in many of our hospitals, and again, this is not HCA specific, we still have a lot of dated and manual processes that drive healthcare delivery. These are all real pictures from acute care facilities across our network, where we have a lot of technology, but the technology doesn't interoperate. A lot of it is dated. You can see a picture of a wall phone there. If you walk into a hospital, I guarantee you'll see someone pick up a phone and call pharmacy asking, where's this medication or what's going on. And so we haven't digitized our platform. We haven't kept pace necessarily with the technologies that are available to us. And that's not because, we're not good people interested in technology. It's because healthcare moves slowly for a reason. We have people's lives at stake. And so the adoption of new technology moves slowly and cautiously because ultimately we're responsible for incredibly important outcomes. But what this has created is people as the patches for these systems. So, and I think EHRs are the best or worst example of this, depending on how you want to call it, where we deployed a system that was intended to create a more digital and data-driven platform. But it just turned into another job for our care providers, where now they have to enter all of this data into a system in addition to taking care of the patients. And the system wasn't necessarily designed to make their job of taking care of the patients easier or more effective. It just was another job. And you can just take that example and then multiply it. We once looked at this, and our nurses have 52 different technology systems that they interact with on a daily basis in our acute care facilities, and 63 different systems that are capable of sending an alert to them about something. So the people truly have become the patch, and they've borne the brunt of this technology that we've deployed in our hospitals. But when we looked at this, when my care transformation and innovation team looks at this, we see nothing but amazing opportunity, because these are all solvable problems, and artificial intelligence is going to be a critical tool in solving these problems going forward. But before I get to the fun stuff about talking about artificial intelligence and how we can use it, there's a level of discipline that we have put in place that I think is really required to deploy this kind of technology well. And that is what we refer to as a human-centered design approach. Another way to think about this is really spending the appropriate amount of time understanding the opportunities and the problems that we're trying to solve. So not starting on the left-hand side of this cycle with, hey, let's deploy AI, or wouldn't it be great if we had an algorithm that could predict who's going to be at high risk of readmission? That's sort of starting with the tech and the data. Instead, start with the opportunity and really understand, okay, why is this problem occurring, and what's the workflow associated with it, and why do people hang on to that workflow? And then recognizing that for healthcare delivery to get better, people have to change their behavior. We're not here in the business of trying to replace people with AI. We can talk about that, but I pretty firmly believe that's not where we are right now. And so ultimately, it'll still be the people delivering care. And so their behaviors and their workflows will have to change if we're to adopt these new technologies. So there's an order to this process that we follow pretty religiously in my group to ensure that we always know what problem we're trying to solve before we jump to shiny new tech objects that we want to go chasing after. So when we started this work about 2.5 years ago now, the first thing we did was we went to our hospitals. We actually have 2 Innovation Hub hospitals that are basically our laboratories, places that we've trained how to do iterative design and change management and all these other things that are hard and don't necessarily come naturally to healthcare workers. And we asked our hubs, as well as lots of other stakeholders, what problems should we solve? And the friction in healthcare delivery just kept coming to the top of the list, that to get our work done, to have time to think and make critical decisions, we end up getting consumed with all of these other administrative tasks and burdens that just don't need to be there. And so the idea that we could make care frictionless was one that we attached ourselves to very early on. And so 2 domains that I just want to share with you that we've worked on, and I'll get into the examples here quickly, are right people at the right place and the right time. So that's basically clinical labor. How do we deploy our clinical labor in the most efficient and effective way so that we always have the right team to take care of patients? And then the second is more time on patients, less time on paperwork, which anyone who's in and around the healthcare industry, I think immediately understands the problem that represents and the opportunity. So the first solution that we built, and we've been at this for now about 1.5 years, we call Timpani. And this is a transformational approach to labor management. So in most healthcare organizations, the labor management decisions in terms of building a schedule, maintaining a schedule, assigning a care team to a set of patients is still a relatively manual process. There might be some data involved, but it's mostly manual decision-making, and it consumes an enormous amount of time of nurses and nurse leaders, and at least in our data, results in a pretty mediocre outcome in terms of the experience as well as the effectiveness of deploying our labor, which is what you would expect when you have 3,000 different nurse leaders across 183 hospitals, all sort of having to figure this out independently. And so we saw a better path forward. And again, we borrowed a lot from other industries, the airline industry in particular, and set out to create a fully automated, digital, and intelligent approach to how we deploy our labor. So how can we measure demand differently so we actually know the work intensity of what's going to happen on any unit on any given day? And then how can we predict that work intensity using artificial intelligence and machine learning algorithms? And so we've done those two. And then pivoting from a self-scheduling model where the nurses just assign themselves to shifts, but without the intelligence to know, are those really the shifts where they're needed, to a preference-based system where we provide rich data to an AI algorithm about how they like to work. And then the AI has the flexibility to use those care team members based on their preferences to meet demand. And then a better way of measuring the capabilities of our care team members, the talent that they have, so that we can assure we're sort of spreading out the experienced nurses and the novice nurses and other care team members in a uniform way. So take all of that rich data, bring it together into an AI schedules for our care teams and our units, and then an ongoing decision support tool that can I think I just maybe lost connection, but hopefully I'm getting back here. A balanced schedule, and then an ongoing decision support tool to maintain that schedule up until the time of actually working the schedule. So that all worked relatively well, but we found that when you got to a hospital level, when you go up from a unit to a hospital level or to a market level, a more rules-based or heuristic-based AI became really, really complicated and very complicated to manage and maintain. But this is where generative AI stepped in. And what we found was we could teach a generative AI, and we've tried both GTP4 and MedPalm for this use case, to understand the data that describes a unit and the nurses and the patients and the rules around how you staff a unit. We could teach it that through a data ontology and then give it access to an entire hospital or entire market's worth of data and let it start giving us decision support, let it start making decisions. So we could ask the AI agent things like, where are there gaps in this hospital that could be filled by floating nurses, for example, or how do I make Friday nights better? And the AI is able to understand that very complicated equation across that entire hospital and come up with examples. And that's what you're seeing here. And I won't go through the entire slide, but across the top, the numbers are the imbalances that the AI has seen in the schedule between scheduled and forecasted demand. And then you can see below the AI making recommendations. And then on the right-hand side, we always ask the AI to show its work so that it can be transparent about why it thinks it needs to make those decisions. Transparency, I would say, is absolutely critical. If the AI can't show its work and tell you how it got where it is, it's probably not ready to be deployed. And I'm going to skip over the video here in the interest of time. So pivoting really quickly to the physician side, so that's a great technology for our nurses and nurse leaders. The physicians entirely focused on documentation when we asked them the question of what problem should we solve. The burden of documentation was the top 3 on their list. So you're seeing here Dr. Alex Denard. He's our chief of emergency medicine at one of our innovation hub hospitals. This one happens to be in Orlando. And he's working with a company called Augmetics, and we actually have this in 4 emergency rooms, using an AI-driven speech-to-text or ambient speech technology where in these 4 ERs, these doctors can put an iPhone down between them and the patient, or we're also testing using Apple Watches, and they can interview the patient, and the AI will transcribe that multi-party event, turn it into text, and then natural language processing and large language models take that text and understand it and turn it into structured documentation. Now, right now, we have a human in the loop. We have a medical scribe that's helping the AI oversee that process because the AI is still learning. But we think by about January, the AI will be able to do this somewhere in the range of 60% of the note completely on its own. And then we have a pretty solid plan about how to get that last 40%, which has to do with the complicated medical decision-making part of an ER note. So at that point, the ER doctors will have an AI assistant on their iPhone that can basically be their partner in completing documentation for them. And this is a platform that we're starting with the ER, but we can go well beyond that once we've figured out all the technology challenges that this platform. Large language models have dramatically accelerated this. Again, one key I'll call out here is human in the loop. So even when we don't need the medical scribes anymore, the physician will still play a critically important role of always evaluating everything that the AI does before it becomes part of the official electronic record. This is just, again, I'm not going to read what's on this slide, but this is an example of what that workflow looks like. So it starts on the left with that multi-party transcription. Then the AI, the large language model, starts to read that and break it apart and create these sections of the note like HPI. And then we have even more specific natural language processing models that can break out things like the physical exam and then the assessment and plan. And so all of this is obviously occurring on the iPhone. You can see that from sort of the structure and the form factor there. And let me finish just with a little bit more on how we're deploying generative AI. So this is an incredibly powerful tool. I've said this before in other settings. Healthcare is language. It's all about communication. It's all about finding information, conveying information, and then making a handful of really key decisions based on that information. So an AI assistant that can help you do all of that first part, finding, understanding, summarizing, organizing information so that the physicians and clinicians and nurses can spend all of their effort on the second part, the critical decision-making, thinking, directly supporting the patient, is potentially a superpower for clinicians. So we've started with a relatively simple but powerful use case, which is nurse handoff. So about 400,000 times a week in our HCA hospitals, a nurse hands off a set of patients to another nurse. And this is, again, largely a manual process. There are templates in the EHR that help, but our nurses tell us what they actually end up doing is something like what you see on the screen. They end up taking notes and writing things down by hand so that they make sure they have all the right information to communicate to the next shift. So we've trained an AI model, in this case, MedPalm, and we're testing MedPalm 2, to be able to read the EHR, and that's not a simple thing. We had to spend a lot of effort to teach it how to read the EHR, and then gave it prompts and instructions on how to create this bedside shift report, which includes a patient timeline, a medication history, an overview of the patient, and even a chat feature where the nurse can directly interact with the AI to customize the handoff. This is still in pilot. We're testing this in 2 hospitals. The AI does a good job at creating the timeline, the medications, and the overview, but hallucinations are still an issue. And so we're working directly with the engineers and scientists at Google to figure out how to structure the prompts and organize the data in such a way that we can factualize the output and limit the hallucinations. I'll give you a quick example. Through the chat function, we actually asked the AI to tell us what the favorite movies were of one of the patients involved in the handoff process. Now, that information obviously doesn't exist in the EHR, and the AI made up answers. Now, it picked pretty good movies. It had good taste, but obviously completely fabricated. And then once you get the AI off track like that, you can just continue to drive it off that track, and it'll go into all kinds of areas, making up all kinds of things. So we're still learning how to control the factualization, but the power of the AI to be able to, in a matter of seconds, read the entire EHR and create this very well organized and intelligent timeline and summary is something that we think is going to be game changing, and our nurses are unbelievably excited. To us, this is really step one. This is learning how to put an AI assistant in the nurse's pocket. There's lots of other things, and I think that was on my last slide, that we can do beyond just a handoff tool once we've figured out these issues. So let me just end here. This is a journey for us. This transformation is not something that comes quickly. It's not point solutions. It's really about transforming how our organization works, how it uses these tools and this technology. It's about learning to do transformation. It's about change management. I would if I had more time, I would say change management about 100 more times, because it's just the most important piece of this work. We can build the most amazing tools, but if we can't get people to want to interact with them and adopt them, it'll have no impact at scale. And so we're in this early innovation adoption phase where things actually may feel like they're slowing down a little bit. We're having to do a lot of investment in data systems and data architecture. An AI strategy is a data strategy. But we see very soon, and we think 2026 is a reasonable target for this, an inflection point where we will have done that hard work. We've built those foundations. We've learned how to use these tools, how to control them. And then we're going to get into this rapid acceleration phase where we can really start delivering better outcomes, better experiences, more efficiency to all of our patients, all of our care teams across our organization. So it couldn't be a more exciting time, I think, in healthcare. There's a lot of incredibly hard work to do still in front of us, but we have the tools at our fingertips really to transform care delivery in a way that makes me excited to be able to do this work, and excited to partner with our care teams and our leaders across our entire organization to solve these problems. So I'll pause there. Hopefully that gives you a good idea of sort of the state of AI being deployed in healthcare systems, and I'm happy to take questions.
Thank you for a very interesting presentation. My name is Jacek Wiskam from School of Information at UT Austin. With all these wonderful tools, one burning question, I think, is patient privacy. How do you deal with data privacy?
Yeah, that's a terrific question. I actually had the opportunity to testify in front of a congressional subcommittee last week on AI in healthcare, and this was a topic that kept coming up over and over again. And so a couple of points there I would want to make. First is, one of the first things we did at HCA when we started this work was to stand up a responsible AI program. And this is a multidisciplinary team: legal, ethics and compliance, information protection and security, clinical teams that work together to create a framework that helps us understand how to deploy AI safely, securely, privately. So all that to say is we have an internal framework that anyone looking to create or deploy an AI solution can use to make sure they've asked all of the right questions about the data and how to keep it secure and how to keep it private. We have agreements with our patients who come into an HCA healthcare system about how we can and can't use their data. And we do have the right, through that consent process, to use their data for internal processes. If we're trying to make HCA healthcare better, we can use our own patients' data to do that. We don't routinely share our data externally with other third-party vendors or others. And so I think we have good processes internally to keep that data safe. The other answer I would give you is de-identification is going to need to become another tool in our tool belt, and really one that we need to focus on. In the past, most of our data systems and our data sets all contained identified data. It contained the raw patient data. I think you'll see in the next couple of years that raw patient data with identification will be locked up and housed in systems that are highly secure, because we don't really need it to train algorithms and to do the kind of work I'm describing. And most of the action will occur in large de-identified data sets, which will allow us to share them more broadly with engineers and others with talent that can help use that data to drive better outcomes, but protect the patients. The next version of that is synthetic data. And so you can actually build completely synthetic data sets based on the underlying raw data that contains no patient information. It's all made up data, but it contains the same patterns that the original data sets contained. So I think what you'll see over the next 5 years is a big shift towards a lot of our data systems relying on de-identified and synthetic data sets, with the exception of just like the actual operational systems where you need to know like who is the patient you're actually taking care of right now.
Hi, Neil Charness here. You already mentioned security. I want to talk or just ask questions about cybersecurity generally. One of our local hospitals, it wasn't HCA, in Tallahassee, was shut down effectively for weeks when it was hacked. And they never said exactly what happened, but I assume it was a ransomware attack. And so at the broad level, to the extent to which you rely entirely on a technology solution, you do throw yourself open to the risk that when those events occur, the entire hospital shuts down. Or it could be a unit within the hospital, but it could be the whole hospital. And so to some extent, workflow has to be, I think, flexible in the sense that you may have to go back at some point to those paper solutions. And are there graceful ways to interleave the most cutting edge type of technology and still enable the unit to survive attacks? So that's kind of a top level question. But then I want to get specific to the case of the large language models, because they can be poisoned. I mean, there are effectively attacks now that people are talking about, certainly in academia, that can, in some sense, destroy the work that you've just done, trying to fine-tune an LLM to your specific situation. That, again, will have to be managed as a security issue as to who gets, access to these systems for learning and verifying and so on. Do you have any thoughts or a quick comment? I'm sorry, it's a very complicated set of questions. Any thoughts along those lines?
Yeah, well, so your first question is a really intriguing one, because there's clearly a balance between wanting to take advantage of these technologies and becoming reliant on them. And I would say that we're already reliant. I mean, when our EHR goes down, which frankly for us happens incredibly infrequently, it's incredibly disruptive. Now you have paper processes by which you can continue to care for patients. But I think over any extended period of time, there would be a big gap between the quality of the care and the consistency and the effectiveness of the care we can deliver when we're on paper downtime procedures versus when we have our EHR that has decision support tools built in, et cetera, et cetera. So you can do it, but it's certainly not of the same quality, I would say, as what can be achieved when we have the tools to support us. So I think your point is a good one. We have an entire team that focuses on nothing but protecting us from cybersecurity, because it's a massive issue. And that I'm not part of that team, so I don't want to provide, misquote them. But I know that we fend off, constant attacks, thankfully successfully, through good technology and good process. A cybersecurity agenda is a sort of data privacy and integrity agenda. So it's sort of all about access and where's the data and who do you give access to. And so again, I think the modern data systems that we're building, where you can sort of lock up the most secure data or most sensitive data really tightly, and then use like data products and de-identified data products for all of the work you want to do, actually really enhances your security and your ability to fend off cyber attacks, because locking up a de-identified data set that doesn't affect us operationally, and so you have to get access to the operational data. And so that separation between those two, I think, actually increases our ability to be safe and secure. As it relates to large language models, I'm with you 100%. I mean, between hallucinations and data poisoning or prompt poisoning, I think we're still not ready for prime time on these things yet. So we're very much in a testing mode. I think that there's interesting short-term use cases that we can deploy them in as a way of testing. So it's hard to test these things in a vacuum. Sometimes you have to get them into workflow to really learn how they function. And so that's one thing our innovation hubs are great at, is they're small controlled environments where we can go break things, and we have enough support and resources there that nothing really bad happens when we do break things. But I feel like LLMs are still in the realm of being used in those kinds of controlled environments, because at scale, 400,000 handoffs a week, it only takes a few errors for that to multiply really, really quickly. So I'm confident we will solve the problems, but we're not ready for that to be, in the hands of thousands and tens of thousands of people. And then your point is spot on. You're going to have to really carefully control who has access to these things and how you give them access. because it is easy to take them off track and to create havoc with them. So I would just say, like, a lot of excitement and interest around LLMs, and I think they will be an amazing tool. But there's a lot of hard work to do before we're really ready for them to be sort of running around healthcare, doing things outside of highly controlled environments.
All right, no worries. First of all, thank you. Thanks for the opportunity. Things on a technical talk about technology. So first of all, just want to thank you for the opportunity to speak today about AI in healthcare and sort of give you my perspective, as well as give some applications from the work I'd done previously before coming here, and then talk a little bit about the exciting opportunities here at the university, in which I think the degree of innovation and opportunity is so significant, and then keeping it in context with the humility that we need as we look at this evolving application. So with that, this just kind of, before I get into this, I just want to highlight, we spend about $4 trillion a year in healthcare. It's the most within the sectors of the government. And despite that, mortality ranks 38th between Lebanon and Cuba. And furthermore, access is completely broken. There's hope that AI can help improve some of those things, but there's going to be a lot of work moving beyond AI to clinical impact is going to be essential for us to really recognize the full power of what AI can bring to transform health and healthcare. This just kind of shows you this period of convergence of capability evolution across a range of capabilities. You can see over the years the acceleration. If you just look between what's happening, if you were to extend this now even beyond 2020, the degree to which AI and handwriting recognition, speech recognition, image recognition, reading comprehension, language comprehension, just accelerating to the point. And you can see over 0 here, that's human performance on the benchmark here. And you can begin to see it excelling over human performance. Research is just ballooning in AI. You can see the growth of publications. But at the end of the day, what's the aim of AI in healthcare? We really talk about the quadruple aim. AI that can demonstrate improved patient experiences, better outcomes, lower costs, improved clinician or provider experiences is sort of like the quadruple aim of AI. We heard a little bit about generative AI and ChatGPT. If you just look what version 3 was trained upon, the amount of data in version 4, you can expect version 5, version 6 are just going to get even more and more powerful. It's no question that ChatGPT and generative AI will change healthcare. It's going to become exponentially faster, more powerful. It's going to begin to emulate how doctors make decisions. It's going to provide around-the-clock assistance. It's going to help prevent medical errors, help doctors perform at a higher level and providers. It's really going to have a role in streamlining drug discovery and development. The entire area of generative therapeutics is huge. It's going to cut the time of clinical trials and the time to discovery. It's going to improve imaging, and it's going to hopefully personalize medicine. But again, those are some of the aspects, and there's a lot that we have to talk about before you fully realize that. Health systems, as we've heard, are already using generative AI in a variety of cases across the value chain, whether it's clinician productivity, clinician decision support, marketing, to sort of list some of the different groups. And there is potential to deploy a much broader set of generative AI use cases, particularly for new health system builds, which we're going to be doing. I'll talk to you about that a bit later. But apart from that, at a high level, I just want to talk about applications of AI in life sciences, drug discovery, and diagnosis and care are broad. We talked about some of them already, just broadly for AI and drug development, diagnoses, virtual nursing assistance, fraud detection, cybersecurity, et cetera. But I think it's really important to also talk, we heard a little bit about its potential to help mitigate clinician, physician, nursing burnout, all-time high. 63% of nurses and physicians will report burnout. The pandemic worsened that even more. Is there a role for some of these tools, as we've heard in the earlier presentation, to actually reduce some of that administrative burden, that clerical burden that's driving some of that burnout? Perhaps. We were all promised that the electronic medical record would make our lives better. It didn't. We're now at home documenting at 9, 10 o'clock at night. So for every time technology was a promise it was going to help, it led to a series of challenges. But again, we have to keep in mind that the potential is there, and we are at a unique time. When you think about the healthcare industry, however, it really lags behind other sectors in advanced analytics adoption. This just kind of shows you across the board that we're one of the lower ones here in terms of adopting some of the promises of technology, and particularly AI. And that's because there's this thing called the AI chasm. what works in the innovation phase and the early adopter phase, before you try to bring it and scale it, just sort of collapses here in what's called the AI chasm. Some real examples of that. Epic had overhauled a sepsis or an infection detection system, put it in, and it just began alarming all over the place, not picking up sepsis, creating problems and challenges, even risk to patients. And that would actually trigger the FDA to say AI tools to warn of sepsis should be regulated as devices. So really began to see the regulation come in. But then the question is broader than that. Why is this chasm from the AI model? Got a great paper, you got a grant. And here on the healthcare side, we're like, is it going to have an impact, a sustainable impact on our patients? And there's a lot of reasons. I'm just going to point to a few of those. Data. We'll start with the data. We have insufficient data often. It's poorly curated. It's all over the map. There's a lack of high-quality real-world data. We might have great data from Mayo Clinic or MD Anderson and these slivers of really highly curated data, but the spectrum of data is lacking in real-world environments. There's limited data standardization, data aggregation, interoperability of the data, tools for open source data transformation, data sharing, and there was a question also about data privacy and security. There's also challenges of the kind of data. So we all think the electronic medical record, great data, images, great, genomics, great, but in fact, the majority of data is getting lost. When your patient gets in the ambulance, comes to the ER, goes to the intensive care unit, all of that data that's really in real time in the acute setting is not there. It's actually not in the medical record. So I think it's important to recognize efforts that try to get to that synchronous data to actually be able to help inform decisions in the moment are critical. Actually, here at UT, they figured out a way to patch what's called sickbay, a lot of this data right into TAC, the Texas Advanced Computing Center. So again, you have innovations happening here at UT that are beginning to overcome some of those challenges as we think about the kind of data. Models start to do crazy things after a little time. There's issues with bias in the model, drift. It starts to behave differently. You think you're detecting flu with the Google flu, and suddenly it's not detecting that at all. Accidental fitting of confounders. You think you're differentiating, wolves from dogs, but in fact, it's just noticing that the wolves were in a winter climate, and so they were picking up on winter, not the difference of a wolf and a dog. Generalizability is challenging. Outcome, noise, unintended negative consequences, which in healthcare is a pretty big deal. You can't have an unintended consequence. You have to trust and understand how you're informing your decision, at least for decision support opportunities. So this whole issue of the black box, not quite knowing how you landed on that result, and now you're going to use that, let's say, at the bedside with a patient who wants to understand, why is this working? What's this going to do? What's the impact? So that comes to this whole concept of trust. Is it trustworthy? Is it transparent? Can we explain it? Does it have a clear benefit? Better than just its performance under a curve? Do we have quality control, safety measures, and accountability? When it does what it's not supposed to do, who's to blame? The computer, the algorithm, the doctor, the health system, the regulator? It's kind of a mess. But on the other hand, we're working through this. The other part, the regulation, it's intended to ensure a basic level of safety and efficacy for license and marketing. Regulatory bodies, however, do not provide normative data or guidance on what constitutes sufficient safety and efficacy of AI. So there is concern for safety when algorithms are applied at scale. Only 126 out of 130 FDA-approved AI devices, they were relied only on retrospective data. Of 54 high-risk AI devices, none had prospective studies to support efficacy and safety. There's a lack of validation studies. You need to ensure that the AI actually benefits patients, clinicians, or the healthcare system. And you also need to have implementation challenges. They're hard to adopt. I don't really want to look at 5 million alerts in a busy day when I'm trying to take care of a complex ill patient. How are you overcoming those obstacles? How do you train a literate AI workforce? How do you have the kind of training, the peer mentoring, the support? It's a failure to seamlessly embed AI ML solutions into existing workflows. And there's financial issues. So how do we bridge this chiasm? We have to think about, first of all, out the gate, the symbiotic relationship between clinicians, data scientists, and really define the clinical goal from the outset. The clinician is best to identify, or the provider, where and how AI could add value to the practice. Data scientists are best equipped to identify machine learning approaches. They have to function as a team, communicating freely, keeping the human in the loop, but it's a circular thing, not just up front, throughout that process. And in fact, it's throughout the entire AI life cycle. So when you think about teams that can work side by side, we have a great environment here at UT to be able to do that. We need to understand what the clinician and patient are dealing with. We need to learn each other's language and build a shared educational framework. And we have to enhance partnerships with informatics, computer scientists, computer engineers to really build products and solutions. And we have to understand that healthcare AI engages stakeholders early and often. It's the health and special care, it's the companies, it's the policymakers, the education and research environment, the private party sector, and the patients, the citizens, the communities are at the center of that. We need a robust data strategy. Texas is behind as a state with a data strategy. It doesn't have a unified data platform. Maybe that'll become obsolete. It has some great data, though, and it needs to think through about what's the purpose of the data and the question it has, because there are some great national data enclaves as well. We need data sharing that preserves privacy and allows us to preserve sort of local control of that data, at the same time being able to move and share models across institutions to assess performance. We need to think about promoting fairness and reducing bias at all stages of the development of AI. So with that, I just want to comment that AI in medicine, really, clinical research is essential for AI implementation. AI clinical trials have to ensure predictions translate, are accurate, and are free of bias. And the mindset shift has to shift from digital product development to clinical management development, and to build the frameworks and the collaborations. We need to build the translational research infrastructure for AI here at UT if we hope to really move beyond the papers, beyond the grants, into impact. We need to create the live environments for that to happen synchronously. We need to create the unified systems across some of our data platforms to really be able to really have the kind of impact and scale we're talking about. And we need to understand this relationship between the human and the algorithm. What does it mean to have a machine on your team? How are you really learning to interact with this machine in order to kind of do this shared team building that's critical with the patient's needs at the center of that? And in terms of an AI literate workforce, just a few comments. All stakeholders have to be involved in AI implementation process in medicine. The workforce has to be educated about AI. It has to understand its benefits and limits. Medical schools, pharmacy programs, nursing programs, residency curricula need to be updated to include topics in health informatics, computer science, statistics. And in an ideal world, physicians and providers would understand at least the basics of how these algorithms are constructed, comprehend the data sets and their various limitations, and really importantly, understand that ultimately healthcare providers will need this knowledge to maximize their functioning on human-machine teams, and in order to be able to advocate for your patients, for your providers, ultimately. So at Mayo, and I'll talk about my years at Mayo just briefly, what was the experience there as a chair of the Department of Neurology and a dean of clinical translational research before coming here? We really focused on establishing a neurology AI platform. And that was to really create neurological care with equitable, high quality, affordable, and widely accessible care through validated institutional and department technology platforms. We were bringing teams together to advance impactful AI, establish a modern integrated data platform for neurological data, and leverage care strategies to improve equitable health care. And we spent a lot of work, and this just highlights, what did I learn from that? Well, first, bring your content domain experts there. 2 world-class neurologists led the program. Build a multidisciplinary team. As the first department to go out and start hiring AI engineers, data scientists, really bringing an application architect, software engineer, sort of building that within the domain, but then scaling it out at the institutional level. So the Neurology AI program has also attracted investments in partnership with Google, UIUC. I'd love to get it now connected with UT Austin. But again, it became a very collaborative environment. Several products were generated. I'm not going to get into all of them, but one of them is something called State Viewer. Here in aging, you're interested to know that, as you know, there's many conditions that can cause similar dementia syndromes. getting an earlier and accurate diagnosis is critical. Our team at Mayo had developed an AI tool called State Viewer, which looks at individual patients' brain imaging or other data to identify patients at Mayo with similar patterns in order to make a diagnosis. And the ability to digitally link patient data could improve diagnostics. This was done first with PET imaging, and for anybody who's ever dealt with PET imaging, it's hard to interpret. We lay them all out on a scan, try to figure out what's what. We've been able to show with State Viewer that we can actually not only pick out the relevant, distinct diagnoses of dementia, but we can even pick up certain dementias that are yet to be classified and identify the underlying genetic disorder that had yet not been identified. So at a high level, machines can do things, but it's really in partnership to enhance the role of the clinician, at least with this product. We've digitized all of the speech at Mayo. So here we've been able to use the same platform to diagnose distinct speech disorders by speaking into a phone. This, again, has not yet been scaled into companies. We're doing all the validation, the clinical trials. The work is being published. The grants are coming in. Actually, on the speech side, a huge effort on privacy. Even just a little bit of speech. It is HIPAA protected. You can't just take people's speech because it can be identified. It set the standard for NIH to how to deal with speech recordings, and so that work is ongoing. We've been digitizing the neurologic examination as well. So, not moving now. Oh, there we go. So we've been looking at basically how to get your data into ways you can analyze it. And so that's another effort that's moving forward. So my take-home message on that is really, again, the importance of domain knowledge, computer scientists, analytics, AI, it sort of sits at that center. And then just in the last couple minutes, this is something that went into a grant, but I just want to highlight it to you. It shows the complexity, but it also shows the opportunity. When one thinks about the spectrum of discovery, translation, application, commercialization, scaling, first, you got to figure out, where are these ideas? How do you capture the innovations that are going on? There's a lot of them going on this campus. How do you create infrastructure to provide some support right out the gate to assess your data set? There's all kinds of data out there. But those of you in informatics know that data is data, but how do you curate that now? That's where data science and informatics comes in, from taking data to information, knowledge, and wisdom, so highly curated data in some models. That drives you to a model, but now you have to develop the clinical trials or the care pathway validation to bring it into practice. You have to bring it in the live environment, then you have to test it in other live environments, other populations before you can implement and scale. And at the foundation of all that, you need some sort of a cloud platform or data unified platform. You need a lot of IT systems, and to the points of compliance, safety, ethics, equity, performance, regulation, that's underlying that. So when you think about where we have strengths, we have huge strengths in compute. We have huge strengths in analyze. We want to build strengths in the applied environment, but we need to create that educational infrastructure to kind of drive what is really a circular process in the AI lifecycle. Here at UT, there's tremendous opportunity for ecosystem integration. The assets here are huge. I came from Mayo after 30 years where there was so much integration, but it was being dismantled or disrupted to get down to innovation because it was so structured. Here, there is so much innovation. You have to create some structure to start pointing at least some collective efforts on some of the shared things we're trying to do without basically creating so much structure that you hamper innovation. But the assets across our schools, the presence of Odin Institute, TAC, Texas Robotics, our plans to build more expansion in our healthcare space. And of course, you know, the Institute for Foundations of Machine Learning was designated as the headquarters here of the National AI Institute for Foundations of Machine Learning. Hop into Austin and you got a lot of interested people around. They want to partner. That's both an opportunity and a distraction. The degree to which the partners can actually bring something incremental, you really need a strategy to vet, weigh that, and then also recognize companies are driving a product, often driving a financial return quickly. But that can be helpful because they can move things fast. But we're in the business of actually trying to also ultimately drive the impact beyond the startup company. We're trying to actually get these things adopted. Now, this isn't what it's going to look like, but we announced back here in August that there was going to be some expansion of our healthcare services including the MD Anderson coming to the campus of the Irwin Center, and UT Austin, called UT Medicine, expanding its hospital as well. These will be 2 hospitals connected side by side, as well as a significant expansion of our ambulatory practice. This is actually a strong collaboration that will continue with nursing, pharmacy, social work, psychology. We are standing up a Dean's Council where each of the deans will be meeting monthly to give sort of input on this effort. This will not be done in isolation. It's not a med school thing. It's a university broad effort. I do think that environment will help us also not be at a disadvantage, because that live environment is important to be working in this effort of what's transforming in medicine. The fact that we kind of have a green field is a chance for innovation, leapfrog innovation. So we can hear from other groups what they're doing in the country, but we can build it from the ground up. We're not going to build a hospital that's obsolete by the time we stand it up. It will be an AI, digitally enabled, agile hospitals, but they will be centered on a patient-centered design, and they will have to demonstrate superior outcomes, improved efficiencies, and really enhanced experiences for all. I would just close with the fact that breaking down silos and aligning incentives is important. We need to break the silos down between academia, the clinical environment, and the tech industry. And everybody worries about AI replacing people. I don't see that it's going to replace providers, but I do think that AI, whereas it's not going to replace clinicians or providers, I do think those clinicians who do not work with AI will be replaced. And that means in our training programs and everything we're doing, we need to think about this. But the world of medicine is being transformed by technology. It's an opportunity also not to lose sight of our humanity and the ways in which we need to really have that technology walk alongside with us without really replacing that side of what makes us human. So with that, I covered a lot. Hopefully it gave you more a sense of the spectrum of the field. We're really excited this year, 2024. I mean, Jay Hartzell's calling it the year of AI. What does that mean? Well, we could all scramble around and try all doing things, which is going to be important because of that innovation at a local level. But I think there's real opportunity to bring several programs, whether those are centers or institutes, collectively across the schools together, whether it's a deep assessment of your own data assets and thinking about how those can be best positioned. At Mayo, when we started standing up the neurology AI program, the expert here, David Jones, who I asked him to lead this effort, he said, Claudia, you're going to spend a lot of money over 2 years and get nothing if you don't really spend time establishing a technology data platform. It's just going to go out the door, you know. And so I listened to him, and we spent 2 years figuring out how to get time series data migrate into the cloud, making sure we had a way to curate and unify our data, and that we had a translational infrastructure to help move that forward in a way that we believe now can start to move an impact. Each of those products are now part of our live environment at Mayo, but they haven't been scaled. Nobody's paid for them yet. We have to now see, to really have the impact we hope, that team will have to be able to now start to thinking about the validation that has to happen broader. But again, I'm excited about the future, recognize its limitations, and I'll pause to just answer any questions. So thanks for having me.
Thank you. Thank you so much for that amazing talk and for everything you're doing in the system. Some of us who are researchers here go the next step, which is, so the physician comes to all of this brilliance, and now it's really up to the patient to do what they've been told to do, right? So patient compliance, patient understanding, all of that. Do you see the next step as to how AI will play a role in that, or will it not play a role in that?
So what do you mean by the patient? So in terms
the patient gets the plan and is told, you know, you need to take this medicine, you need to talk to the nutritionist, and I need to see you in 6 months.
Yeah.
And the patient does none of that.
Oh,
so
you're talking about compliance as in, compliance.
Yeah, we've got this brilliant health plan for you, but the person who ultimately has to implement it, what happens next?
Well, that is a complex reasons, multifactorial, but you're completely right. Having patients, so first of all, there's multiple non-medical drivers of health that impact that. One thing to give a plan to somebody who then goes out and can, you know, barely make ends meet and isn't going to go buy the medicine that you just that they're going to be charging how much of their, you know, annual monthly income on. So there's that issue. Number two, there's the issue of education in terms around, particularly in technology, digital literacy and digital access. So now I give you a great plan, it's on your phone, and you go live in a broadband desert. You have no access. So during the pandemic, we found in Minnesota, the rural population would be driving to McDonald's to get access to broadband because that's where they could get it. They weren't coming to appointments also because they were not trusting it, like they wanted to see you in person. It wasn't something they were going to do remotely. So then the healthcare started to plummet, the access, because they didn't want to come. Understanding those barriers, the role for implementation science and community-based participatory research is critical. Co-developing solutions. So we develop a CV app, cardiovascular app, to look at improving cardiac health. Well, it's one thing that I develop and hand it off to you and you go use it versus it's co-developed with the very people who are using it and understanding different populations. Certain populations won't even put a smartwatch on. It's adorning, it's jewelry, it's not something part of that culture. Have we brought the cultural humility to our design phase? It's one thing to say it's people or human-centered. It's another really to take the approach that's going to be needed and understanding how you tailor care while at the same time looking at the broader context within which our patients are living the moment they leave your office. That make sense?
I love it.
Not an
Thank
answer.
you.
It's
I
just
love it. And I think that from the point of view of a lot of us that do research, I think that's a really great way to think about it. So, I mean, who do that next step research.
Yeah.
Thank you so
and
much.
that's partly why when I'm looking at research, and we can take all about the data science is important, the engineer is important, but the implementation scientists, the community-based participatory researchers, and the people that understand those factors at a broader level are so critical. And if they're left out of the process, it's just not going to go where it needs to go in a sustainable way. So.
Anyone else? Oh, there's another question.
Morning. My name is Rebecca, and I'm a student in the School of Engineering. I was wondering, how do you see wearable devices being integrated into clinical practice, and would that necessitate another form of data, another database?
Yeah. So that's partly why we're all mesmerized by the electronic health record and think that's the end-all be-all. But in fact, the majority of the data won't even be in the record, and it'll actually be the record is when you're actually in the bricks and mortars of your place of living. So wearable sensors will be critical. Healthcare is being radically disrupted by technology. Less care will occur in hospitals and clinics, and more will occur in homes. The wearable sensors won't just be something on your smartwatch. Over time, it'll be sensors in your teeth that are looking at your diet. It'll be your mirror that is going to give you physiological information. It's going to be different kinds of streams, which will be overwhelming. If we think care is fragmented today, imagine every company with its own way of collecting that data. So we're in the storming phase of innovation right now, but yes, the wearables will be important, and understanding how to standardize that data, migrate that data in a platform that can actually interpret it, and having a broader strategy is going to be important. But the wearables are helpful. The pandemic accelerated care outside of the hospital, outside of the clinic. We now can leverage some of that. It's just going from a cool sensor, a cool kind of thing, to actually adopting it and using it and having digital endpoints that we all agree upon. If my sensor says, uh-oh, this tells me I've got something, or other, my glucose, my blood pressure is off, but someone else's sensor has a different threshold, and we have to create unified digital endpoints, and we have to create a digital technology translational environment to kind of work through that as well. So there's a lot in that space, but it's exciting to think about it. There's also a lot with ingestibles. Ingestibles are going to be playing a role in diagnostics. We have a unique opportunity here at this university with the kind of engineering that's here, the various schools coming around it, and so it's just sort of coordinating, deciding where are going to be the key places we want to play to win, so to speak, meaning make our mark to accelerate something that's going to have impact on our patients, on our outcomes that we talked about.
I'm not a scientist or software engineer or any of that. It just seems to me there's an over-reliance on this data, and how do you protect it when AI's got it wrong? Because when you play around with ChatGPT, you can just go down those bunny trails and come up with all kinds of wrong information.
Well, first of all, people are using the word AI to throw all kinds of AI in there. generative AI is one. Large language models is one kind of data for use. And it does hallucinate, and it is based on what's out there. It's also not completely up to date, but it can be used as an adjunct or as a tool in certain environments. Discovery AI is another thing, and that really depends on often very highly curated data where you're using it to build a model, and then you're testing that model, but you have to have the quality management systems in place that aren't linear, meaning you didn't just put them into, let's say, the hospital system. They're constantly being reevaluated, in a circular way. And we're not really set up for that. So that's the second thing. But there are, I think, real opportunities out there. If you can diagnose conditions like, for example, let me just think, an easy one, an EKG. You can get a regular EKG, and it can predict now if you're at risk of developing left ventricular heart dysfunction in the next 5 years. You don't have it now, but your EKG has just signaled something that I didn't see on your EKG, but is going to do that. Well, that's a good thing to know, because I might do different things now. I might go in, I might go have different medications, I might have different treatments. Now, on the flip side, let's say it's predicting that I'm going to have some future problem I never have, and I spend a load of money doing a load of tests of which it never comes to bear. Well, that wouldn't be a very good thing either. So we're having to work through its applications in a rigorous way. And the principles of being rigorous and right is, in my opinion, more important than being fast and first. Companies want to be fast and first. We're in the business of being rigorous and right. But those cultures have to come together. Sometimes we perseverate over being rigorous and we never move. And on the other side, we just fly in and do something that doesn't make sense. So at the end, it's the merging of those cultures that I think will get us there. But we can't play a passive role in it. It is happening. It's here. And so we need to figure out how to shape it for its intended, not its non-intended use.
All right, so now for something completely different. I'm going to go into a little mini study that attempts to address a question that I've been wondering about for a little while as an older adult myself. The question is, should aging adults trust chatbots? And I want to thank the National Institute on Aging for funding this as part of the CREATE grant. This is a program project grant that's been going for almost 25 years of continuous funding from the National Institute on Aging, concerned with empowering aging adults through technology. So, and the image I put up there, I just want to clarify, is one that was generated by Dolly. So I didn't steal it anywhere off the internet. It was with a prompt, something like skeptical senior having a conversation with a chatbot. All right, so I want to give you a little bit of context where I'm coming from. This study is really part of a larger, our center's called CREATE, and it's version 5, project that's focusing on trying to support older adults in their healthcare decision-making. Because we've moved from a model where essentially the physician told you what to do to a model where the healthcare professionals are there to help you make the decision by yourself with their aid and with appropriate information about potential positives and negatives for adopting a particular form of treatment. Now, originally when we wrote our grant, we planned to provide our own digital assistants to try to make, or at least help older adults with decisions concerning kind of 3 toy domains. One of them was Medicare, one was long-term care insurance, and the third one was the issue of locating local health resources. And then along came ChatGPT about a year ago, actually. And so instead of deciding if we can't beat them, maybe we can join them, or at least maybe we can make better use of them, we pivoted to a goal of instead trying to help older adults learn to use these new tools. And so one of the first things that we were interested in was trying to understand how good those tools were. And in this case, we were interested in trying to assess and score the reliability and accuracy of the sorts of very complex responses you get from these large language models, these chatbots. We also are interested in stability because they're constantly undergoing change. And so you don't know what model you're actually working with because changes are constantly being implemented. And the other thing we were kind of interested in was, how good are they getting? How do they compare with earlier AI systems, like the types that are already in the homes of some aging adults, Alexa, Google Assistant, Siri, you can name them all yourselves. So the background was really the issue of trust. And so we were interested in trust in AI. And there are a number of polls that were taken fairly recently. And in general, it turns out the American public is relatively skeptical about relying on AI. This is a poll done by Pew in 2022. This is before, I guess, ChatGPT came on the scene. Indicated about 60% of Americans would be uncomfortable if a healthcare provider relied on AI, whatever that means. I mean, they didn't define it really. And it turns out, if you look at the data here, that trust tends to decline somewhat. I don't know if I can't, let's see if I can point to it here. Trust tends to decline somewhat with increasing age. So about 56 to 57% would be uncomfortable. By the time you get over 50, it's closer to almost 2/3 of people are not happy with the idea of a healthcare provider relying on AI, however they interpreted that. Now, where did this trust, or in this case, mistrust, come from? Is it with people's experiences with these types of AI systems? So there was another poll that Pew did back in 2017, and then the more recent poll. In 2017, they reported only about 37% of Americans age 50 plus had experience using, for instance, digital assistants like Alexa, compared to 55% of people in younger age cohorts. And a very recent poll that is this year by Vogel's showed that although a majority of Americans had heard, this was early on, this was, I think, roughly December of 2022, so just after ChatGPT, or along the time that ChatGPT came along, a majority of Americans had heard of it, but very few had actually tried to use the system. So you can see it was at about 21% for the very youngest cohort. It was at about 0.14, so 14% in 30 to 49, 7% 50 to 64. Only 2% of aging adults 65 plus had ever tried to use those. So where's this mistrust or distrust coming from? Well, for that, we need to go back and look at some relatively, in some cases, old models that were generated in the human factors literature on trust. And this was in the context of trust in automation in human machine systems. This is around the time that aircraft that people actually flew in, civilians, had fly-by-wire types of systems in them. And would people get on these planes knowing that they were basically being controlled by machines, with the pilots not taking as active a role in many of the circumstances? And Lee and C was probably one of the most influential models. And what it was essentially pointing out were that trust seemed to be generated in different stages and at different levels of what they call calibration. So an important concept, and I think one of the questions already today pointed to this, is that you ought not to trust a system, over-trust a system, when it's inaccurate. Your trust ought to be calibrated to the level of accuracy or reliability of a particular system that you're dealing with. So there are kind of zones, and I haven't got the time today to get into all these issues. But the other thing that was pointed out is trust is something that's embedded in a context, an individual, organizational, cultural, and environmental context. This is the managing of workflow issue that was alluded to in the very first presentation today. The more recent model is the Hoffman-Bashir model. And I want to just point out very few features about how trust is engendered in people. So people start out with kind of what they call dispositional trust. How many people here have tried to use some of the new large language models like ChatGPT? probably about half the people in the room, maybe 2/3 in this case. And so initially when you come in with certain expectations. Those expectations are based on your general information. As we saw, most of the American population hasn't played with these systems, but they had mistrust almost immediately, and it wasn't based on interaction. So you start out with dispositional trust, and then initially, then you start to interact with these systems, and you can now build up trust that's a function of your interactions with these systems, dynamic trust. And again, I won't get onto this. This model also talks about reliance on the systems and reliance strategies and how these things change over time. But all I wanted to point out is that there are a couple of features that you need to keep in mind when you're asking the question, will people trust, say, large language models or whatever? There was a very recent meta-analysis that came out by Kaplan, Kessler, Brill, and Hancock in 2023. And what they showed is that there were 3 factors that were significant predictors of trust. These are from studies of people interacting with AI systems. One of them is what they call the characteristics of the human trust, or dispositional factors that I discussed a little bit earlier. The second is the characteristics of the AI trustee, the system. And you can see, and then of course there's the shared context, the nature of the interaction once you get to people finally interacting with these systems. But what you can see is, these are effect sizes, so standard deviations. These are huge. So what seems to be really important initially for the systems that you're interacting with is their performance, not a big surprise. Something doesn't work, you step on the gas and nothing happens in your vehicle, or I should say step on the accelerator, because some of you own EVs perhaps. That's a huge factor. But a second important factor is the reliability of the system. It might give you a right answer today, but will give you a right answer tomorrow. So this led to our study. We were interested in assessing the accuracy of AI assistance in the context of answering queries about Medicare. And we used a question set that had been developed about 20 years ago by Ban and McCormick that was developed and tested against a very large cohort, a representative sample of Medicare beneficiaries. So when we found this study, what we said was, okay, good. Now we have some indicator of how humans do in this situation. How do the bots, the chat bots, compare with those humans? We added 12 questions because back 20 years ago, there was no Part D to Medicare. So again, we're in a changing environment when we're dealing with things like Medicare. And we generated them from the Medicare and U.S. government Medicare handbook. I received that in the mail, a while ago. A lot of you received it in the mail if you're over 65. And that's a source of information. And we used 2 commercially available large language models, Google's Bard and ChatGPT 4 through Microsoft's Access in Bing. And we also wanted to compare it, okay, so this was an unfair contest, I agree, with Amazon Alexa and Google Assistant, because there were models that are out there that have been experimented with that older adults and in some cases interacted with. And we wanted to assess the experience of presenting questions to both voice-based chatbots, and many of the LLMs are now getting voice interfaces, Alexa and Google Assistant, against what was at the time text-based chatbots, Bard and ChatGPT 4. And we queried the voice-based systems with an English speaker with a standard Midwestern accent. So here's an example of the sort of questions that we were dealing with. These were true-false questions. Is it true or false that Part A of the Medicare program covers hospital stays? And here are the responses. Google Assistant said, here are some results from the web. We scored that 0 because it really didn't answer the question. Alexa said Medicare Part A covers the hospital insurance program, including hospital expenses, skilled nursing facilities, home health care, and hospice care, which we scored as 1 correct. ChatGPT 4, that's true. Immediately gets the right answer on the question, and then goes on and elaborates. And the winner in redundant and excessive information was Bard. So yes, answered the question, but also generated a lot of additional information. And we're struggling with this. This is an ongoing study, and we've got some other ways of trying to score responses of chatbots to try to address whether or not they may overwhelm someone who's searching for a relatively simple answer to a simple question. Okay, so how did we score? So the digital assistant's query responses were transcribed in some cases if it was auditory, but in other cases it was there on the screen. And then 2 independent coders to the authors on this particular paper that's under review, myself and Emily, tried to score them independently. We discussed our disagreements and then made a final assignment to each of these responses. And we were working with about 83 questions. So it was a fair number that we had to go through, took a little bit of time. And the raters rated the answers as correct if the content of the answer aligned with the sentiment expressed by the corresponding answers in the original, except for the new questions, Bannon-McCormick questions. So they had, we used them as the gold standard. And we didn't, in this part of the project, look at conciseness, which is a problem, as you've just seen. So how good was inter-rater reliability? Not bad. We assessed that with Cohen's kappa, which is a measure of reliability, percent agreement. Raters were in 100% agreement for all the bot's responses to what were called terminology-based questions. There was pretty strong agreement between raters for non-terminology questions. For ChatGPT, Cohen's kappa, 0.847, 84.9% agreement. BARD, we had 100% agreement, which was amazing considering how lengthy those answers could be. Alexa, it was 0.848, again, very strong agreement, 84.7%. Google Assistant, 100% agreement. So there was nearly 100% agreement across those 2 raters regarding the original and Part D questions we generated. And there was close to 100% agreement across raters, across all the bot responses when we re-queried them about a month and a half later. So this is the stability question, or the reliability. How much can you depend on these bots? So we did an initial test and we looked at accuracy, and you can see BARD stayed at 100% over the roughly 1-month retest period. ChatGPT went slightly, but not significantly down. Things do get worse as these models ingest more data for reasons I've kind of alluded to. They sometimes get wrong data because they're picking up everything on the internet. And as we know, there's a lot of misinformation out on the internet. Alexa did horribly, and Google Assistant didn't do particularly well either. This is in the context. If you look at domain, we also tried to look at accuracy by the types of questions and so on. But let me just go through this, or just show you a slide. So we looked at the different aspects of Medicare that people might have queries about in terms of trying to make decisions. And you can see, in general, only BARD and ChatGPT were significantly above the average Medicare beneficiary in the accuracy with which they can answer these questions. So let me just draw some quick conclusions. Our goals in this particular study were to assess, first of all, how reliably can we score the responses that come back from ChatGPT and other chatbots. Compare the accuracy to earlier systems, and particularly to human response. How good are humans at answering these same questions, particularly the target audience here, Medicare beneficiaries. And we also wanted to try to assess chatbots over a 1 month or month and a half period. And our scoring reliability was quite high. The accuracy of the LLMs was very high, virtually perfect for Medicare terminology, greater than 90% for knowledge-based queries. The stability was generally high, but we observed nominal decline for ChatGPT. Other people have found this. Although in general, these bots are getting better, in some domains, they seem to be hiccuping a little bit. So let me get back to the big question. Should older adults trust chatbots? We'll say at this point in this domain, for the types of questions that we were using, yes. For the large language models, no, don't consult Alexa, don't consult Google Assistant, unless you're also willing to follow up the links and verify for yourself. So, but I would say for decisions, we're looking just at the information accuracy here. We didn't ask the bots to make decisions. You can do that in a different project. I've already started to look at that. So you might want to, in the words of Ronald Reagan, trust but verify with either a Medicare subject matter expert. There are helplines that you can get hold of, SHIPS programs that the states all run, where you can talk, you could talk to a real human expert, a subject matter expert through Medicare. Now, lots of caveats here. This is one short study. Chatbots are continually undergoing change, often improvement, but not necessarily. And older commercial bots are soon going to become the brains of the new ones. Google will be replacing Google Assistant with Bard fairly as soon as they can. I imagine Amazon also has their own LLM models that they're going to be developing, and they will be replacing, I'm sure, the Alexa chatbot. The other issue, and I've kind of alluded to it, is Medicare information is a very large knowledge domain, one that the US government recognizes as difficult to query and hence provides human helpers to the people who have to make decisions annually. Do I keep my plan? Do I change my plan? And how do I enroll in it in the first place? And they provide human experts, advisors by telephone to supplement the Medicare website and the printed materials that they release annually. And we examine the performance of those systems on a relatively small subset of potential queries from a very large universe of queries that are there about Medicare. And it was based largely on question sets that were generated roughly 20 years ago, with some additional ones, but we don't have ground truth or on the accuracy of humans on those particular questions yet. And there are also, those of you who get into it and use these systems know, there are a whole range of decisions you have to make about how you query them. There are different levels of settings for LLMs. Do you want accuracy? You can have one setting. Do you want creativity? You get another setting. You'll get many more hallucinations in the creativity setting, and so on. So we chose only one. We chose the balance setting simply because we know that a lot of work on human factors with aging adults, they tend to stick with defaults. And so whatever the default setting is what we essentially started with here. So that's it. Thanks for your attention. Open for questions.
Let me see. Yeah. Thank you for the presentation. It's very impressive. I'm Justin from School of Information. I also doing research on conversational agent for older adult health. So yeah. So my question is like, when I review the past research, I'm wondering, what, in your opinion, to what extent do you think older adults can depend on the chatbot for the health information and decision making? Because in all this research, there are two groups. One group, they think they can make health information as easy as possible for older adults. And the other approach is like, I want to explain as much as possible to older adults, like how the decision generated, and that's them to in full control of that. So I think it's a question of a different level of dependence on that. So I want to hear about this from your opinions.
Yeah, thank you. As usual, these are really difficult questions that we're all struggling with in terms of trying to provide technology support to aging adults. Because they have, as you've alluded to, they often have very different levels of digital literacy. They have very different levels of health literacy. And so what you think might be a very helpful response to somebody who's relatively highly educated may go completely over the head and not be of little use and be culturally insensitive to somebody who is of lower health literacy and technology literacy generally. At this point in time, I would never advise someone to rely on these bots, even the very best of them, for decision making for them. Rather, the issue is, can we teach them how to use them to gather the most accurate, reliable information that they can get from these systems? I'll give you kind of a personal example. So as an older adult, I have lots of chronic conditions. Well, not lots, but I have chronic conditions, and I'm sent blood tests, and I get blood tests back, and I get abnormal results on it. Now, I'm smart enough to be able to look these things up on the internet. I'll go to Mayo Clinic site, for instance, for reliable information, but there's lots and lots of misinformation on those sites. So for fun, I fed my abnormal test results into ChatGPT and said, give me a differential diagnosis for a 75-year-old male for these test results. And I finally got my appointment with the medical professional, and lo and behold, the medical professional and ChatGPT agreed virtually 100% on diagnosis. Not 100% because as usual, I get sent for a whole bunch more tests. We were alluding to this, the increased costs of misidentifying or wrongly identifying a condition. That's a serious problem for the healthcare system generally. But yeah, so the issue is, how do you titrate information in a way that it's useful, doesn't take over the decision-making side of things? One of the things we're learning in the Medicare area right now with our projects, is a much broader project than what I just described, is that people are absolutely overwhelmed by the amount of information. Those of you who may be older are getting ads on TV like crazy now, because we're at the end of the period now for making your enrollment decisions. And they just want to be told what to do. What we're hearing from the professionals who give the advice when you phone Medicare is that people are desperate to be told what to do. They don't want information. It's too complex. We've given them too much. They just want someone to help make the decision for them. Yeah. Might go to a friend. We're beginning to learn how decision-making by aging adults takes place in the real world. And that hopefully will guide us in the way in which we're going to develop systems and educate people on how to use these systems effectively. Sorry, very long-winded.
That's insightful. Thank you.
Okay.
Hello, thank you for such a wonderful presentation. You gave me something really interesting to think about, because both she and I did a study on ChatGPT and its responses to dementia caregivers' questions that they ask on social media. And I was really curious to see about your scale and how you decided to sort of rate the incorrect or correct or appropriate or inappropriate.
Yeah, it's really tricky, yeah.
Yeah, and we were thinking about that, and we ended up developing a 5-point scale. One of them was comprehensiveness. The ChatGPT got a score for comprehensiveness, and I didn't really think about the other side of that, which you pointed out, which is being concise. And so thinking about, how we, as I'm a clinical social worker by training, how we as a clinician make that human judgment in a patient visit about how much information the person in front of us wants at this time, how much is going to overload them versus how much to give them in sort of bits and pieces. And, that's something that a chatbot just can't do. It's like, is it so concise it's not enough information versus, this overwhelming amount of information that is comprehensive but way too much. So thank you.
Yeah, we're busy working on scoring schemes right now in a different part of our project for exactly the reasons that you just mentioned, which is you can get overwhelmed very easily. And the degree to which you're going to be overwhelmed easily is also probably a function of your background knowledge of that area or that field. And then when you get into really difficult judgments like what would have been the right advice to give, you just don't know in some cases. I'll get into the kind of the purchase of, because this was a discussion at a very nice dinner I was at last night with Dr. Fingerman and colleagues. How do you know whether you should be buying long-term care insurance? And, when ChatGPT came out, that was the one I first actually started to ask it. I asked it, like, should a 40-year-old buy long-term care insurance? Should a 50-year-old? That's the next question. Should a 60-year-old? Should a 70-year-old? By the time I kept pushing it, of course, it was saying, it's your birthday, you should definitely buy long-term care insurance. So it was led down a rabbit hole very quickly. I should have mentioned, on this particular project, we reset all the bots after each question was asked. So we didn't run into hallucinations at all in this particular study by doing that reset. That helped prevent it. But again, that's a piece of information you'd have to give to, say, an aging adult who wanted to query these systems as to how best to use them in a way that will minimize the possibility that they'll get incorrect information out out of the query. But yeah, everybody's struggling with this. Again, maybe we should exchange notes on this. We're all trying to put together scoring schemes. The problem is reliability tends to drop the greater the number of distinctions you make, which is why we're really happy with the Bannon-McCormick. Most of them were simple yes-no binary questions. And it was a lot easier to do the scoring. But we're experimenting with that right now. So yeah, we should sit down and chat.
Yeah, I'd love that.
Hi, Dr. Charness. Amazing talk. Thank you. So, like I was trained in psychology department when I was undergrad, so I may think like a psychology student. So, when I get in touch with ChatGPT, the first question came to me was that can we use ChatGPT as an intervention for example, older adults that have the problems such as loneliness. So in that case, it's a question of whether ChatGPT can provide emotional support rather than informational support. But as we know, ChatGPT change constantly, and I don't know in a study how can we really look into this question and whether it's possible for ChatGPT to do that.
Yeah, I think it's a very good question. There's a whole realm of social robots that people have been developing, and commercially so far they've been failures, but eventually they may be helpful enough that they could perhaps be useful in this issue of trying to combat loneliness. And loneliness is a bigger problem actually in your generation than in older adults' generation. If you look at the loneliness literature, and the people who were hit hardest in COVID were not aging adults, it turns out, at least in the early studies, but people in their 20s and 30s in terms of anxiety and so on that developed, and loneliness, social isolation. I'm not using they're not identical. One is an objective characteristic, social isolation. The other is a subjective feeling. The success in the robotics field so far with the social robots, I say, is fairly limited. There's some clinical trials with Paro, which was this very early kind of pet seal that was put together. They're not very good studies, but there was some indication they were helpful in nursing home environments. What we've found, I've been working in this field for a long time. CREATE's been together almost 25 years now of continuous funding through NIA, is that for the most part, older adults don't want technology to substitute for human contact. They want it to augment human contact. We see this particularly in the telehealth field and telemedicine. So I don't think you're going to be able to take a lonely older adult, get them trained up to use ChatGPT, and that will be their main outlet for social interaction, even if ChatGPT could do this very successfully, which at this point in time, it's an open question, I think. So you really need to think of technology as augmenting, and this was pointed out, I think, by Michael as well in his presentation too, augmenting, supporting human beings by providing access to certain types of help or information or social support, not replacing the human side of the contact equation. So I can see it as supplementing, but augmenting, but not replacing human contact.
Join me in the work. Thank you. I'll take it. All right. Thank you, everyone. Thank you for staying up to this point. So could we? Yeah, okay. All right. So normally when we introduce the last speaker, you start with the last, but not the least, right? Okay. So in this case, I'm going to start with the last and the least speaker, and that's me. Okay. So my name is Boshi. I am a professor in the School of Nursing with a joint appointment in the School of Information. So my talk today really will be focusing on one of the most recent research projects we are working on. But first, let me put in a little advertisement. So we have a new center
research center, the Center for Healthcare Innovation and Technology Advancements, CHITA. It's a new research center started out in the School of Nursing, and I hope that I'll have some time today at the end of my presentation to talk about what this center is and the exciting opportunities we are going to develop. All right, so acknowledgements, research. This was a R56 grant funded by the National Institute on Aging, which is part of the NIH. It's an R56 grant, which means high risk, high reward. What that means really is a 1 year of R01 level funding. So NIA likes how risky our project is, that they think it's innovative, but they also think it's too risky to give us 5 years of funding just yet. So I'm hopeful that we'll be able to go back and convince NIA to give us additional funding after the first year. Now, my research over the years has focused on the intersection among older adults, health, and information technology, and specifically focusing on information. And it's not just about any information, as the other speakers have already mentioned. It's information being communicated to the right people in the right format and the right time that can be used by the people to make informed healthcare decisions. And the technology really has become a key gateway to information and services and opportunities. So technology really has introduced a lot of new opportunities. And this is our wonderful research team. Alisa, who is actually here today. Thank you for joining me today. And then we have Robin Hilseback. So Alisa and Robin are our clinician experts, clinical experts on our team working with dementia patients and caregivers. And then we have Da-Qing He, who is at the University of Pittsburgh. He is our machine learning and artificial intelligence expert. These are absolutely some of my most favorite people to work with. All right, so our team's long-term goal is really, as I mentioned earlier, we want to help caregivers get information tailored to their health information wants, defined as the types of health information caregivers want to have in order to better manage the daily care for a person living with Alzheimer's and related dementias. So this is a very quick overview. Now, I know some of you who have been working with me for longer, you probably already know the punchline, but please don't say it until I get there. Okay, so essentially we want to have caregivers enter text into our system, and then our system can generate a tailored response. And we start with understanding what information caregivers want to have. And then we also try to match that with care strategies. And the care strategies are really sort of the evidence-based general care strategies that we normally would give. And then we have tailored narrative. So the tailored narrative will be tailored to the specific individual, tailored to their personal context. And how we want to do it, now you remember this is from our initial R1 proposal, which then turned into this 1 year project, R56 grant. Initially, what we thought we were going to do was, well, we're going to use natural language processing and the machine learning tools to help us understand what types of information caregivers want to have based on a large quantity of social media posts, so that we identify health information wants, HIWs, and also we collect information about care strategies from credible websites like the Alzheimer's Association's website and the NIA's website. And then we extract and organize the care strategies, also personal information that we can use for personalization. And then we'll be able to provide a response containing care strategies that corresponds to the caregiver's health information wants and appropriate personalization. Now our plan, I see Neil is smiling already. Okay, you see where I'm going. I'll give you a quick example in terms of what our team has been trying to achieve. Now we thought, okay, for example, we have a caregiver-generated text. This is a real social media post that we collected. And from this post, then we use machine learning methods to identify that, okay, this is a post representative of memory loss and confusion. And we say HIW 4.5 because we actually have developed a knowledge base that includes 7 different types of information that caregivers want to have in terms of providing daily care for dementia patients. And under the 7 categories, there are subcategories for a total of 35. And then we also identify personal context, like my grandmother. I mean, that's a part of the piece of the information that we use for personalization. And then we also developed our framework for providing care strategies that should focus on educational information, sort of like the more general information, and also tangible action, specific things that a caregiver can do right in the moment in order to really make a difference. Also referrals, and then personalization. And then we have our system will generate a tailored narrative response, right? Or sounds good, right? Okay, so now I'm going to give you an example of what the response should look like. It's a bit long, but let me try to run through this. This is a great response because it includes general information in terms of care strategies. It also includes tangible actions, specific things that a caregiver can do. Also referral information. Also, it provides personalization. It's all about like your grandmother, she, her, wonderful, right? So this is a great response, right? It's been done by ChatGPT. So when we first found out, we were like, oh my God, are we going to lose our jobs? Because we did propose that we were going to do this. And then suddenly we realized, oh, wait, ChatGPT already can do it. So remember all this, like all these different pieces of puzzle that we said we were going to do, but now suddenly realize, whoa, actually, all these things we don't need anymore because right now ChatGPT can already do it. So it's essentially you enter a social media post or caregiver enters any text, and then through artificial intelligence, large language models, and then there you are, you get a response already. So our team, we had our panicking moments. We're like, okay, how are we going to convince NIH, right? How are we going to even ever to do anything with clinical practice? And then we thought, okay, at least it's good in the sense that our long-term goal is achievable already, or achieved somewhat, but maybe perhaps that was just one offshot, right? Maybe ChatGPT got lucky that if we do enough testing, sooner or later, we will be able to identify limitations and weaknesses of ChatGPT that we can overcome. So that was an idea we started with, and then we did this side project. We started with a research question. This is actually very similar to Neil's project, where we want to know if ChatGPT can actually generate high-quality responses to real-world questions asked by dementia caregivers. So we did this side project. And we actually, our team, Alisa actually represented our team to present this talk at the Gerontological Society of America's annual conference just a few weeks ago. It was great. It was a wonderful presentation. So if you have any more, if you want to know details about this project, Alisa will be here ready to help out. But let me just get to very quickly. So what did we find? High quality. Now, after Dr. Charness' presentation and also our previous speakers, there's no surprise that you already know it's really high quality. So we used a scale on 0 to 5 points. About 45% of the ChatGPT responses were rated as, or 5, they received the full points. And then another, was that 25 or 35? 35 received 4 points. The remaining about 20%, they received 3 points. But no ChatGPT response received less than 3. So that's really high quality. And then now we are thinking, okay, what are we going to do? But luckily, since we are trained as researchers, trained to be critical, right? We were still able to identify limitations, which is promising in terms of keeping our jobs. So one limitation, for example, is ChatGPT was not able to understand the subtleties in human conversations. For example, if as human experts, when we read a text that says along the lines of our grandmother's late-stage Alzheimer's was getting so bad that she could no longer be living in her
house by herself, so we moved her into a home, and the staff there are taking good care of her. So with human experts, when you read this text, you know the word home means a nursing home, right? But ChatGPT was not able to tell that difference. So when it comes around for ChatGPT to generate recommendations for, well, if the grandmother runs into any problems at this home, what should we do? And then ChatGPT recommendations will not be specific to a nursing home. Instead, it thinks it's a private home, and these are things you can do, but that are really not applicable. Another limitation, actually, I did have this, so ChatGPT's limitations. Another example is that human experts often with experience, we are able to anticipate problems that machines are not able to, at least for now. One example would be if someone says, well, my father is really endangering himself driving around, but we can't get him to quit driving. And then ChatGPT recommendation could be, well, take your father in to get a driving test. And that's totally fine. However, for a human expert, like Alisa sitting here smiling already, because you already know that maybe, most likely, very likely, the person with dementia will refuse to take a driving test. And then a human expert will be able to already anticipate that problem and then try to provide some solutions already. But machines are not able to do just yet. Human limitations, of course. We are trained to be critical, right? So when you sit two academics together in one room, how often can you get us to agree on just about anything, right? So I was especially amazed with Neil's presentation where you were able to get 100% agreement. We absolutely need to discuss with you in terms of how you were able to achieve that, because with our team, we really did have quite some discussions in order to reach consensus. And in part, it's because we have different disciplinary training and preparation. Now, for example, for a neuropsychologist, they may say, well, in my training, topics XYZ are a must. So if the machine did not mention XYZ, I'm going to rate it as not comprehensive. But versus another expert in a different field, like maybe social work, you may say, well, XYZ never has been a problem for me, so it doesn't matter. So I'm just going to say the ChatGPT response is comprehensive because I don't talk about XYZ in my consultation with patients and caregivers anyway. So it's not a limitation per se. It's more like that's how our human society functions, right? So could ChatGPT actually do better, or do we want to have different versions of ChatGPT responses, like maybe a version of ChatGPT focusing on a particular field, like neuropsychology or social work or pharmacy or something else? Of course, it could also be our study's limitation because we had a small sample, did it very quickly. Our rating scale might have had a ceiling effect. We had only 5 points top, but if we had, let's say, maybe 100 points, then maybe we'll be able to identify more limitations with ChatGPT. But so why is this relevant? It's very relevant because I really feel the pressure of having to work harder to keep up with technology. Feel like like when I take a break, when I have my lunch break, I listen to ChatGPT videos and the YouTube videos to get the most recent updates. Every time I feel like, oh my God, I'm so outdated already. It is really going to change the way we live, the way we work. And I think I especially like, I think it was Dean Lucchinetti, when you mentioned this, technology is not going to replace clinicians, but clinicians who do not play with AI will likely get replaced. So it's the same applies to researchers as well. So what are our plans? After identifying the problems with ChatGPT, with our research vision, we started thinking, well, for our team, we did have a plan. We actually worked at, we wrote a new proposal. And the proposal was submitted, and it was out of my desk, November 6th. And at that point, I told my collaborators, I'm like, well, with NIH, there's a 90% of chance that our proposal will not get funded. So let's just be prepared, mentally prepared. And then as soon as we submitted the proposal, we saw the OpenAI Dev Day, the new excitements, where you can build your own GPT, and just like building a mobile app. I'm like, okay, now let's bump that up from 90% to 95%. There's a 95% chance we probably won't get funded because what we propose to do is already sort of outdated. And that's very scary in many ways. But we did have a plan. Our plan essentially involves not wasting anything that we have already done. Because with machine learning, training large language models, a big part of it is that you needed to really have a high quality training data in order for the models to work. And I think with our team, our expertise and the hard work we have done over the years, including our health information wants framework, our daily care knowledge base, and also our care strategies framework, and also the representative posts that we have identified from social media posts. Those can be used as seed posts to train the algorithms to perform better. So I think with all that hard work, we will be able to train our own model that will be better. Now, in part because better is defined also as we needed to be sure, we need to trust the models. Now with ChatGPT or other, like even with more recent ones, GPT-4, if we get 100, 1,000, 1 million responses that we think are high quality, can we trust it enough to say, okay, let's just roll this out for everybody to use? I know I wouldn't as a researcher because I don't know what's going on with this black box. With this black box, anything can go wrong, and it's a risk we cannot take. So in order for us to have full trust in the system, we need the transparency. And the transparency cannot be really gained with OpenAI's products. So our project, our team's goal is really to train our own open source large language model using the pieces of hard work our team already has done in the hopes that we will be able to ensure control of what goes into the large language model and what comes out so that we can really be sure to control the quality, and also we can be sure to protect the privacy, ensure data security. And that is a direction we are heading into. But of course, there are broader implications for our project. And I'm hoping that I think what our team has experienced is not unique. I know many other research teams are going through the same. And how are we going to catch up? It's very hard for people like us working in the health science space, working as researchers, and the technologists, they're going to move forward with or without us. So we need to come up with ways where we are not behind, and hopefully, maybe we will be able to even try to help steer the directions to make AI more ethical, more applicable, equitable. And also in terms of how we assess the quality of ChatGPT responses, it's very hard because with machine learning, machines really do require what they call the ground truth, or what maybe perhaps in the health sciences or elsewhere we call it like the gold standards, right? So we need to have something to assess the quality of the responses. But if even humans cannot agree fully on how to assess the quality, then it's going to be problematic for us to assess machine quality. Anyway, so there's a lot more opportunities for collaboration, but I think I need to move on fast. Okay, so I mentioned just 30 seconds. So with our new center, this is really exciting. And we are going to actually start this Health IT Speedy Proposal Assistance and Research Knowledge Grants, Health IT Spark Grants, which is really a pilot grant that we are really trying to speed up the process of clinicians working with technologists based on the most recent technology developments that hopefully we can make a difference in clinical practice, in research, and in everybody's everyday life. If anyone might be interested, please let's have more conversations after today. Well, all right. Okay, collaborations, social behavioral researchers, clinicians, computer scientists, interdisciplinary collaboration, really, so this is really, anyway, I'll be quick. Well, thank you so much.
Thank you so much, Bo. I think that we've come around full circle to where we started. And what I'm going to suggest is that we're just a few minutes over. So what I'd like to suggest is that we're going to have a lunch, and Bo is going to be here, and she is also accessible by email. She'll be around for the rest of it. And so I'd like to thank everyone for coming to the panel and for being a part of it, to encourage you to eat, to encourage you to talk to Bo. And I think we've gone around full cycle as to how it is and what it is and where we need to go to improve healthcare using these amazing opportunities that are here right now. Thank you to everyone.